Hello, my name is Dr. Rashan Jayakumar, and this is a clinical vignette presentation on a case of Pembrolizumab Induced Diabetic Ketoacidosis and Takotsubo Cardiomyopathy. Pembrolizumab is a humanized immunotherapeutic monoclonal antibody which binds to programmed cell death 1 receptor on T cells and is used in the treatment of many malignancies including renal cell carcinomas, non-small cell lung cancers, melanoma, lymphoma, and other solid organ cancers. By suppressing PD-1, tumor cells are prevented from suppressing T cell activity and allow for induction of apoptosis. There have been a few cases of Takotsubo cardiomyopathy associated with this medication. Additionally, there have been cases of immune checkpoint inhibitor-induced diabetic ketoacidosis, pneumonitis, and hepatitis. In this case, pembrolizumab is suspected to have caused TCM and diabetic ketoacidosis in a patient with metastatic renal carcinoma. A 64-year-old woman with metastatic renal cell carcinoma, hypertension, and chronic kidney disease presented to an acute care facility with progressive lethargy. She was diagnosed with left-sided renal cell carcinoma and achieved remission following nephrectomy 12 years ago. However, 3 months prior to this presentation, she was found to have recurrence of her cancer after a CT scan of the head revealed a 2.5 centimeter lesion in the third ventricle with hydrocephalus. This was confirmed with an MRI of the brain revealing an intraventricular mass with obstructive hydrocephalus. Staging CT scan showed multiple solid masses in the right kidney, a right upper lobe solid pulmonary nodule, and a pancreatic head mass. CT-guided biopsy of the right kidney nodule confirmed metastatic clear cell renal carcinoma. The patient was started on combination therapy with axitinib and pembrolizumab infusions over 2 months. The patient presented to our acute care facility 8 days after her last infusion, after she was noted to be hyperglycemic at a follow-up visit. Laboratory investigations demonstrated evidence of diabetic ketoacidosis and acute kidney injury. EKG showed ST elevation in the anterolateral leads. High-sensitivity troponins were elevated in the 5,000s range. A left heart catheterization revealed non-obstructive coronary artery disease. Ventriculography exhibited severe anterior and anteroapical hypokinesis consistent with Takotsubo cardiomyopathy. A baseline transthoracic echocardiogram, depicted in Figure A, demonstrated a left ventricular ejection fraction of 20 to 25%. The patient was treated with IV fluids, insulin, metoprolol tartrate, and lisinopril during the hospitalization. A follow-up echocardiogram performed after 4 days showed improvement of her LVEF to 25 to 30%. The patient was discharged home with furosemide, metoprolol, lisinopril, metformin, and a life vest. In this patient, new-onset type 1 diabetes mellitus developed secondary to pembrolizumab. The mechanism by which this occurs is not well understood. The patient remained on insulin therapy on subsequent follow-up visits, consistent with most reported incidences. The development of Takotsubo cardiomyopathy was related, as systemic stressors and catecholamine release play an essential role. Although rare, several cases demonstrate association of TCM with pembrolizumab. Cardiotoxicity has been identified as an adverse event associated with immune checkpoint inhibitors, and cancer is independently associated with TCM. However, the addition of pembrolizumab could synergistically contribute to the pathogenesis. DKA likely added as a systemic stress, inciting TCM. In support, most endocrinopathies associated with immune checkpoint inhibitors occur within 12 weeks of initiation of therapy. This is consistent with our patient. This is the first case to highlight the association of pembrolizumab in the pathogenesis of both TKA and TCM together. Thank you for listening to our clinical vignette presentation on a case of pembrolizumab-induced DKA and TCM.